Hi, good morning, good afternoon, good night. This is Vince Berghella at AJOG MFM for AJOG MFM Highlights. Together once again, and now it's a tradition with my good friend Mhatre.
Hi, everyone. Nice to see you all. I'm Mhatre. I am a maternal fetal medicine attending at Tufts Medical Center and the fellowship director for the MFM Fellowship at Tufts. For those of you who haven't joined us before, we select 4 articles that we want to highlight from this month's issue of AJOG MFM. Here is the list. Here we've tried to identify some very interesting studies that I think will be applicable to a whole host of providers caring for our pregnant patients, not just our MFM colleagues. We're going to be showing them in visual abstract presentation, but feel free to read the papers in their complete form on the AJOG MFM website. We'll get started with Dr. Berghella.
So we try to focus on randomized studies and systematic review and meta-analysis to kind of give a broader view of everything. The first one, it's a systematic review of intervention in early pregnancy among pregnant individuals at risk for hyperglycemia by Erica Werner and colleagues, so Dr. Clancy and colleagues. They were looking at what intervention can be done before 20 weeks in patients at risk for hyperglycemia that may impact fetal growth, may prevent LGA, macrosomia, etc. They actually found 70 studies, of which 65 were randomized trials, so lots of different interventions. And what they found is that all these 4 interventions, like goals and motivation strategies to improve diet and exercise, lifestyle coaching that foster autonomy, structured group exercise and diet obviously is really important for preventing diabetes, LGA, macrosomia, and personalized diet recommendations. All of those, again, from level 1 evidence, mostly decreased macrosomia, LGA, SGA, and excess neonatal adiposity. So the point that we're trying to make is there's a lot of things we know already, and that's one of my pet peeves. There's a lot of things published, level 1 evidence, and for this, in particular in this case, for intervention before 20 weeks to decrease the risk of abnormal fetal growth in patients at high risk for hyperglycemia.
Certainly something we should be trying to counsel our patients on regularly, since it's such high-level evidence, I think.
Yeah, and do it more often,
Exactly.
Do it routinely.
Exactly. The next study is by a group that was trying to evaluate the anxiety, depression, and stress in pregnant patients, specifically who are hospitalized, and how treatment may improve their perinatal mental health. So we obviously know that mental health in pregnancy is very important, but most of the studies have been looking at interventions in the outpatient setting, and there isn't a lot of research focusing on the inpatient setting. But there have been some studies, and this group wanted to evaluate what the effect was of interventions in a randomized trial. So they did a systematic review of 5 databases. Ultimately, after paring down who actually did RCTs and had a control group and focus on the inpatient setting, they were able to identify 3 RCTs of a total of 489 patients who were exposed to either an intervention versus treatment as usual when they were admitted to the hospital. And those 3 studies evaluated mean scores for anxiety, depression, and stress based on standardized questionnaires. And in this meta-analysis, they found that having these interventions, and they range from mindfulness techniques, psychoeducation, and stress reduction management training. These kinds of interventions were found to decrease the rate of anxiety, depression, and stress in these antepartum patients who were hospitalized. The hard part is that the patients varied in how long they were admitted and what they were admitted for and what their prognosis is. So certainly may need to be a bit individualized or trying to find out what the right intervention is for the right patient. But I think this highlights an important need that we have in our hospitalized patients, and certainly more research is needed to focus on this particular population.
So the next one, it's on novel machine learning applications in peripartum care. This also it's a review, a scoping review. on something very hot, machine learning applications in peripartum care. They included at the end over 400 studies, so there's another big review looking at where the studies were performed, how machine learning can be used in OB practice, and what are the implementation challenges. Eventually found that the two leading countries where this data is coming from are the US and China. Most of these studies were on predictive modeling and some on classification tasks. And these apps for machine learning kind of covered breadth somewhat of OB, fetal distress, acidemia, preterm birth, delivery mode, birth weight, etc. Importantly, they found that only 1% of the models were in clinically acceptable tools. So a lot of this, is research not yet super clinically applicable, but they did conclude that there's considerable potential, obviously, for machine learning. So these big models, big data, AI in obstetrics, and there is a need. Basically, the paper is also not only a review, but a call for externally validating, these machine learning models, for transparency, and for addressing regional disparities, because what works in one place may not work another place. But really, it's a very, very hot topic. The Pink Journal is focusing on artificial intelligence and machine learning, and this is one paper that kind of puts the data so far in a good summary.
Wonderful. And our final paper for presentation this month is looking at the association between dietary inflammatory index and adverse pregnancy outcomes. There have been studies looking at focusing on noticing that pro-inflammatory diet has been associated in pregnancy with adverse outcomes. And there was a study, I believe, from Japan that suggested in the preconception period for multiparous patients that having a pro-inflammatory diet would change outcomes or affect outcomes. And the thought is that our diet can maybe modify some epigenetics that will ultimately impact pregnancy outcomes. But studying this in the nulliparous population hasn't yet been evaluated, and that's what this group chose to do. They looked at a secondary analysis of the new mom-to-be prospective cohort, which followed over 10,000 patients in the United States. And almost 8,000 of those patients filled out a survey that was capturing about 120 different food or beverage options that they surveyed about how often they took it and what they took in the preconception period. And then those diet choices were divided into various degrees of pro and inflammatory foods. And then they evaluated those patients to see a composite of adverse pregnancy outcomes like hypertensive disorders of pregnancy, preterm birth, SGA, and stillbirth. What they found is that in the quartile of patients that had the highest pro-inflammatory diet compared to the most anti-inflammatory diet, the pro-inflammatory diet quartile had a higher rate of composite outcome, and interestingly, a higher rate of stillbirth. Sorry, the arrow should be flipped. Higher rate of stillbirth. And so it's interesting because, stillbirth is a multifactorial process. We certainly don't want to say that association is equal to causation, but it may be interesting to figure out if there is some important counseling to be done in the preconception period about our diet for our pregnant patients or to pregnant patients to be, and counseling about this potential finding to decrease their risk of adverse outcomes in pregnancy.
It's interesting, Mo, as I'm mulling over these results, I love the phrase, we are what we eat. And, with the stillbirth data, so worrisome, it's also like our baby is what we eat, what the mother, what the pregnant individual eats. Anyway, this concludes our review of the March AJOG MFM Pink Journal issue. We thank you very much. We want to say, actually, we will do April issue in a week.
Yes.
Again, 9 o'clock Eastern on April 1st. No,
March 31st.
March 31st. Next Monday, 9 a.m. And we look forward to seeing you there. And thanks, Mo.
You're welcome. Thanks, guys. See you then.